Awesome, thanks.
All right. Well, welcome everyone to the January 25th edition of the Provider Update. Thank you so much for joining. I just wanted to, I think most of you know me on the call, but I'm Miranda Durham, the Northwest Regional Health Officer for the Department of Health. And on the call, we also have Dr. Laura Parajon, who's our Deputy Secretary. And we usually tag team this meeting. Sometimes Dan Burke joins us, but I don't think is available today. And then I know everyone knows Chris Schroeder from RTS, who graciously hosts this every week. So we're going to go through some slides. Always want to leave time at the end for your questions. So we'll just go ahead and get started. The NMDOH mission is to ensure health equity and working with our partners to promote health and well-being and improve health outcomes for all New Mexicans. The focus of that obviously has been on COVID vaccine and testing for the last 2 years. So just a little bit of data overview. The community transmission rates across the United States remain high, with a 7-day case rate of 1,511 per 100,000. That's nationally, not New Mexico. That number makes New Mexico look great. And a 7-day percent positivity of 26%. So this is just the county view, and you can see pretty much everywhere is high transmission. This is New Mexico specific data from COVID Act Now. Interestingly, there is this like little squiggle at the top that does make you wonder, is it possible that we're turning the corner on Omicron and coming down? I guess we'll need to wait and see. Unfortunately, you can see our infection rate, which is the next slide here. Our effective remains at 1.35, so down a little bit, but still a fairly high number. And our test positivity rate also a fairly high number. I thought this was interesting. This is a slide from our state lab on the S-gene target failure rate. This is how we how the lab takes a guess that they're dealing with Omicron versus Delta. And the 5-day average for S-gene target failure is 92%, and that was of January 18th. So we're basically at 100% Omicron in New Mexico, which we kind of knew, but this is the proof. The genetic sequencing just takes a lot longer. Here's our vaccine update. We are at 44,200 doses for the last week. So, again, we were at over 80,000 doses a week before the holidays. It dropped during the holidays. It's now kind of up and down a little bit, but still a lot better than last summer. And then a few updates. I just always like to point people to the updated policies. And right now, the thing that's been changing the most is the 5-day isolation and quarantine, as CDC continues to tweak its message, and then New Mexico follows suit. A lot of it is around schools, but they do continue to update the policies for prevention and control of COVID in New Mexico. It's on the front page of the website. It's actually kind of trimmed down a little bit with a lot of links to CDC. So very, very easy to read. And it was last updated January 25th. The most recent update is really sort of including kids in that up-to-date language with vaccines. So this is one of the charts from that document. I don't think there's any changes in that from last week. But I just like it as sort of a quick reference on who needs to do how much quarantine and quarantine. The vaccine updates, nothing really affecting our giving vaccine, but did just want to point out that Pfizer announced today the first Omicron-based vaccine candidate that they announced that they were going to be studying. So, we've been kind of talking about that, like when will a variant-specific vaccine come out? And it looks like that is starting to happen. It's going to be a study of healthy adults 18 to 55, 3 cohorts, some people who are already fully up to date, boosted with the regular Pfizer will now get this. There's some people who haven't been vaccinated at all who will be in one arm of the study. And then some people, I'm probably mixing this up just a little bit, but some people who've had 2 doses and are going to get a booster of the Omicron specific. So anyway, just in case we think we're ever going to get to the end of vaccinating for COVID, it doesn't look like that's going to be the case. Other vaccine updates, I think we talked about this last time, but again, just the keeping an eye out for immune compromised people. And they are now due for a booster. So those people who got the 3rd primary dose right when it was approved August 13th are now coming due 5 months later for a booster. And that booster can be mix and match, and it follows all the booster rules for everybody else. So half dose Moderna, full dose Pfizer, and in certain rare circumstances, the choice could even be Johnson & Johnson. And then also, I know we talked about last week, but just reminding, like up to date, kind of the new CDC language for describing everyone who's gotten as many vaccines as they are eligible for. Fully vaccinated continues to mean someone who's received their 2 primary series vaccine or the 1 Johnson & Johnson. And then I just put a little note to myself here, Pfizer for kids 6 months to 4 years old. I don't have anything concrete on this, except for maybe it's going to have a maroon cap. But I did just want to put it kind of out there on people's radars, and maybe at the end get a little feedback from people, because I think this is definitely a more difficult group to vaccinate. 6-month-old kids are already getting a lot of other vaccines, and this is probably going to be a 3-dose primary series. So anyway, more to come on that. And then the other one is just the Novavax, which is just a different, it's not an mRNA, it's not a viral vector vaccine. So, and that is very slowly, seemingly working its way through the approval process, although it was approved by the World Health Organization. So I think that might potentially be a 4th option for us. Just a quick reminder about VaxView NM. This is where people can track down their own vaccine record. Now includes a QR code that will scan in to your phone, and people can present it as proof of vaccination. And then some slides on race and ethnicity. So we do continue to have, this is looking 5 and older completed vaccine series by race and ethnicity. So we do continue to have a gap with our Hispanic and African American communities, less vaccinated than others. Interestingly, our American Indian Alaska Native is one of the most vaccinated groups. So real shout out to all the work that IHS and other tribal partners have done in protecting that community. The continued gap in race and ethnicity for 5 to 11-year-olds, I mean, it just kind of parallels, in every age group. When we look at this, we see essentially the same lineup. All right, quick testing updates. These are testing options in New Mexico. Maybe we'll just let this, people can take a look at it in more detail, but basically the state does have a test site directory, findatestnm.org. It isn't real, it's just a place that people can list their information. So a lot of them link to other, like Walgreens is on there, but links to their own scheduling site. So we're not controlling the schedules or have no control over the schedules, but it is a place people can go look and get some ideas about where they might get tested. And then for symptomatic testing, PCR is still recommended, not always easy to find. Screening and surveillance testing, we're really trying to move that to rapid antigen testing. Whoops, are you, sorry. If your employer requires screening testing and you're an employee not up to date on vaccines, rapid antigen testing is recommended. Okay, close contact or exposure testing. again, rapid antigen testing is a good way to go for that. If you have insurance, that does cover the cost of rapid antigen tests. And now, as we know, there is the Biden administration program that people can order tests. And I've just been encouraging people. So here's the link here, covidtest.gov. Try to just get on there, put your order in. Don't expect it anytime soon, but they should start to roll in the next week to 10 days. But then it's one to have on the shelf. This is just the test results by week over the last year. I wouldn't pay too much attention here to the 6% decrease from the previous week. Overall, you can see that we've had a great increase. Sometimes because this is really results and not tests done, we get little lags in data reporting. But and then this is the federal program. And on this website, it actually does have information about what to do about a positive and negative test if you scroll down. So that's helpful. And again, it is so easy. So really, you put in your name and your address. There's no choice about what you order. So anyway, it'll be fun to see one day if that test shows up. This is also just to let people know the CDC has a program called Increased Community Access to Testing, and we are working on, so they basically send a contractor who will do high volume PCR testing, and we are looking at these 4 sites starting full blown on February 2nd, Expo, New Mexico, Santa Fe Fairgrounds, Las Cruces, Field of Dreams, and the Lee County Event Center in Hobbs. And then the home test program we've talked about. Most of the first 1 million tests have been distributed to community emergency managers or county emergency managers. And the next 1 million we are waiting for. Those will go to counties pro rata. Just a little shout out to San Juan, who actually sent us some pictures about their distribution, which we really appreciated. Here are the boxes of iHealth. And they've distributed to over 40 locations. These again did need to, or were meant to go to high SBI areas, which they did. One last testing update is Project ACT, Access COVID Tests. That's in partnership with the Rockefeller Foundation with a tentative implementation date of this Friday. That will be another mail order program where you get on the computer and order but this one targeted at high SVI communities. It'll be 175,000 tests, but basically 35,000 households because it's distributed in packs of 5. And with all these mail order, our hotline is available. People can call and get help with ordering. So I'm going to leave it there and turn it over to Laura, and I can move the slides forward.
Oh, great. I actually updated some slides, so I'll go ahead and just put mine on since I think you have to refresh it. Yeah. So, okay. So great. Thank you so much, Miranda. Thanks every week for doing this and working on all these things, and also for our whole team here, our whole vaccine team, and Chris and all of you who are doing so much work in the community. One of the things that we wanted to update everybody on today was the Health Advisory Network, our HAN network. So I would love to just hear from people in the chat if you do get these HANs. So basically, it's a way for us to reach out to providers and get information, give out, disseminate information. It's a little link here that you can get to. I guess maybe we can send that out later, but basically you can register to get them directly to your email, but we've also put them on the website. Thanks again to Chris and his team for putting these up. So anytime we send out an HAN now, that will now be updated on our website as well. And then you can either, link on to sign up or see the most recent HANs that we put out. So yeah, I just know that when I was working at UNM, I didn't get the HANs and I didn't, know about them. So we just wanted to try to get it out there and figure out how to get information that's rapidly changing to everybody. So please type in your suggestions on the chat box if this is a good way to get information or if there's another way for us to continue to share information. The latest update, Han, that we are putting out has to do with the COVID oral therapeutic utilization. As you know, several weeks ago, Paxlovid and molnupiravir started being on the market for us here in New Mexico through the state distribution system. And you can see that molnupiravir, people have been prescribing it, but Paxlovid not as much. So we're not using our whole state allocation of molnupiravir and Paxlovid. So what we did was also look at the usage. So sotrovimab is gone up, but obviously Regeneron and Bamedi, we can't use that anymore. So these two in orange and blue of some hospitals were still using it. They're no longer using that. So it's only sotrovimab. So you can see there's not a lot of sotrovimab. So best option is either Paxlovid or molnupiravir for those non-hospitalized patients at risk for severe COVID. So what we did was the medical advisory team met with the Department of Health to update the OMAS score. So as you know, the OMAS score is the score that you can score your patients to see who's most at risk. So we are still triaging, figuring out who's most at risk for getting into severe COVID. But we did add another point here to any other underlying medical condition associated with high risk for severe COVID. And here's a link to the CDC guidance so that, we've heard a lot of feedback from many of you in the community. Pregnancy should be an independent risk factor. We've heard from some of you that some of your patients who had a lot of other comorbidities weren't able to get Paxlovid. So what we did was lower this scoring system so that it's a 3 instead of a 6 for Paxlovid. So previously Paxlovid, in order for you to get access to Paxlovid as a patient, the score was 6, it's now 3. Remdesivir, obviously it's harder to get, it's 3 days in a row, so not everybody is using that IV infusion, but that also is a score of a 3, and sotrovimab as well, a score of 3. The other thing we did was lower molnupiravir to a score of 1, and also give some recommendations here on the side of preferences, like what's first tier, Paxlovid and remdesivir if you can get it, and then second tier for sotrovimab, reserved for those who Paxlovid and remdesivir are contraindicated or unavailable, and then are outside the treatment window for Paxlovid and remdesivir. So this Han will be put out this afternoon, most likely, and it's supposed to go out this afternoon, but here it is on slides as well, the information that you may need for prescribing. The other thing is for prescribing the oral therapeutics, you can include on the prescription date of symptom onset and OMAS score, and OMAS of 3 needed for the prescription, just everything I just said right now. And then obviously check for drug interactions. The prescriptions go to the community Walgreens pharmacy. This is the phone number and the fax. And then this is a FDA fact sheet you can give for patients, parents, and caregivers. And here's the link here as well. The remdesivir is now FDA approved for outpatient treatment. FDA approval facilitates the reimbursement. So I know it's hard to do the 3 days, but since we just don't have enough sotrovimab, this is what we've got. It removes a manufacturing limit to hospitals, outpatient providers. You can now order and set up remdesivir clinics if you would like, and it's given IV daily infusion for 3 days. We are working with FEMA to see if there are outpatient clinics who need support. It's possible that you can get support from the FEMA PA program, especially if you're a nonprofit clinic. This is the other piece is the participating pharmacy is once again just Walgreens right now. Patients will have their prescriptions overnighted to their home. I know we've heard there's been some difficulty in that. We are using the hub and spoke system to distribute the sotrovimab right now. So the hub hospitals are the ones who are being allocated the sotrovimab. Prescriptions are for everybody. And so, but we have heard that there's difficulty in terms of getting testing in your clinic. So we will share with you some links at the end, like contacts, to try to get some of those rapid tests to you if you're having trouble with getting testing. Because I know the issue is like, are we testing people rapidly enough for them to fall within the window? And then this is the current list of participating pharmacies that you can check and just make sure that, you know, they actually have availability, and that's updated here daily. We have an amazing pharmacy team, and you heard from Courtney last week to really, they really update everything, and you can see, you know, in the moment what's available. Hopefully this is going to get better, but what they did say that we're not going to have a lot of allocation until after March. So that's, and the same for sotrovimab. In terms of billing, the medication is paid for by the federal government. They will bill the dispensing, you know, fees to the patient's insurance, but patients who are uninsured will not be turned away. And uninsured and underinsured patients may have their fees billed to the HRSA COVID-19 CARES program or the Coverage Assistance Fund. And here's more information. And we really don't want anybody who can't afford it to not be able to get the medication. And then here's just some updates that we did. We're just to send these out because we've been hearing a lot from our community, some community members, that people are trying to, you know, understand better the 5-day isolation and quarantine. So some of the key messages we're pushing out is that if you have symptoms of COVID, don't wait, isolate. That was from Hawaii that Miranda and Chris got from our team. And just shows you symptoms and kind of reminders to stay at home. This is an update too for, like, I think what's happening is people are like, oh yeah, we'll just do the 5 days at home, but then not necessarily remembering that they have to wear a mask around others for 5 more days. Sometimes people are like going, you know, to work and then they eat with other people unmasked. So just kind of reminders to people that if they have symptoms and they, you know, we didn't have a test, just assume it's Omicron, and just kind of giving them these pictures. Here's a thing that we also thought people could like check it off like a Christmas, you know, days to Christmas, like days till you're done with isolation. Or and so if you test positive for COVID, that's information here that people can use. And then this is the one for you know, if you've been exposed to someone COVID positive, kind of like a nice little like way for people to see if you're not up to date on vaccine, you still have to stay at home for 5 days if you've been exposed. But if you are up to date, just kind of a little carrot to get the booster, you know, to you know, that you can just wear a mask around others for 10 days. So here you go. That's just some more information. Here's some more information you can use in your clinics or pieces for people to, you know, stay at home, what to do, and then, you know, what to do, just not, you know, telling people that, yeah, they should call 911 if they're really sick. This is updates on questions people have asked us about reporting your tests. This is the what we're telling people about reporting their positive tests is that if they sign up for the nmnotify.org phone app, you can use it to report your test results and help stop the spread of COVID. You can enable the app on your smartphone, on Apple, if you have an Apple phone, or Google Play. Once you're registered, you'll receive text notifications if you come in contact with someone who's positive. And then this is a new feature. This just got put in last week. But it basically says if you are positive for COVID, you can report your positivity on the app, and people who have come into close contact will then be notified. And I know Chris Schroeder is working on an app to make it easier to get on this app. This app is currently like, you have several steps that you have to take in order to get a notification. And then it's all by, you know, it's anonymous and it doesn't use GPS. It's just kind of like if you've been with someone for more than, you know, the 15-minute time and 6 feet, I think they just trigger, right? And then this is a great way for us to try to like take steps to test themselves and stop the spread. This is a new thing, just went live today. Other people were really interested in trying to report their home tests. So our epidemiology response division worked really hard to get this up so that people can optionally decide to report their home test just to the Department of Health. So this is the link I shared in the previous one, and you can report your self-administered test through this portal. And yeah, so that's just a way that we're sharing data. And then guide to mask wearing. I think there's more to come from our epidemiology department, but I thought since there's a lot of questions on that, we just put together what the CDC has said right now. So they're saying wear the highest quality mask you can tolerate, the mask should fit well, you should be able to wear it consistently, and always wear your mask around others. I thought that these links were really great because it like kind of walks you through the different kind of masks if if you're trying to help people decide what to wear. I know most of our clinics are now and hospitals are going to N95s. And the other thing, Miranda, do you know about should we update people, like the federal government is going to start giving out N95s for free. I think they've assigned 3 to each person in the state. So everyone will get an N95 mask, hopefully, and they'll be putting it, I think, in pharmacies and clinics, and then also they'll be giving some to Department of Health to distribute. This is more about what kind of mask to use, and I just thought, it's good to just have the links to these things. So I think this is the update on DOH contact information for providers. Do you want to go over those, Miranda?
Sure. So we basically decided just to try to pull together, I think these are all emails that people have used and know and aren't really new, but just to try to pull it together in like a little bit of a directory. So, and then also to just say, like, these ones, especially COVID therapeutics, COVID data compliance, and the testing are really meant for providers. The COVID.vaccines also was really set up for providers. I think it is where people can, if their vaccine record is sort of messed up, they can send information to the NIMSIS team to get it kind of coordinated again. The COVID testing -DOH at state.nm.us. So if you are a provider who is looking, we know there's some FQHCs who are supposed to be getting some testing supplies and it's just not happening fast enough, then you can reach out to that email. And, if, again, we don't have a ton of point of care antigen tests on hand. We're experiencing the same supply chain issues that everyone has, but definitely doesn't hurt to ask. So send an email, and then largely Stephen Bowling, who's on our team, has been monitoring that email. On the next slide is kind of more patient directed, or not necessarily patients, but the public. And again, the COVID hotline, which has been with us from the beginning, 855-600-3453, really anything that's sort of health related patients and the public can call about. It is also a way to get to an epidemiologist if you're a provider. The Aging and Long-Term Services, it does have an 800 number to support seniors and those with disabilities who need support with vaccine registration and scheduling. It isn't as much of a full-time hotline, but they either pick up the phone or you can leave a message. And then the number at the bottom is non-health related COVID-19 questions. That's also not new. It's been with us throughout the pandemic, but questions about housing. And anyway, it's got a fairly long chain. And we can continue to add to this as people, we were just realizing like, oh, there's a lot of numbers and emails out there. And I think that takes us to the end. Let's see. Yeah. So thank you everyone for joining.
Yeah, and I see there are a lot of questions on the chat. So thanks everybody for all your questions. And maybe we'll just start from the top questions. And I think one of them was one of the questions that we've been getting a lot about immune compromised patients asking for the 4th dose. So do you want to take that one, Miranda? Because I know we've been going back and forth on trying to get the info from CDC.
Okay, so the basic, let's see, the patients, so just a clarification of the way it's supposed to work. If you are immune compromised, you get your 2 doses of Pfizer or 2 doses of Moderna, and then 28 days later, get a full 3rd primary dose. And then 5 months after that, get a booster dose. Pfizer or Johnson & Johnson never got approved for this extra dose. So if you started with Johnson & Johnson, and again, I mean, I'll just say some clinical judgment may come into play, but what the rules from the CDC are, if you're immune compromised and you started with Janssen, then this doesn't apply. So the other thing is the first 3 doses are supposed to be the same brand. Then you can do mix and match for the booster. The problem lies, and so I hope that clarifies. I'm sort of scanning, reading here. So, right, the first 3 doses are then all the same and all full dose. And then when you get to the booster, you can mix and match, and that could be the half dose Moderna, the full dose Pfizer, or again, you know, CDC says mRNA preferred, but you know, there will be some situations where maybe the Janssen is the right choice. The problem that's come up, and I think there's some questions in the chat about this, and we are struggling to get a good answer, is what happens kind of when circumstances change or when it got missed at the beginning. So someone got, you know, the primary series and then waited 5 months and got a booster, and then is looking back and says, wait, I'm immunocompromised. I should have had that 3rd primary dose. And I am going to just say, I'm hoping that we have pushed this up to the CDC. And so hope to have a better answer for you next week on that. What the CDC says is if it's something like you meant to give a full dose, but you gave a half a dose and you realize it right there in clinic, go ahead and give the other half dose and that counts. So 2 halves equal a whole. They also say if you realize it a week later or as soon as possible is their language, like correct it and give the other half dose. What I'm just a little bit unclear about is when 5 months have gone by, if they're still sort of considering that you give a half dose then, and then wait another 5 months and give another half dose. So rather than, just to say there's no clear rule about that. Again, if you do realize the error, or the patient realizes the error in a reasonably short amount of time, they just go ahead and get the other half dose, then wait 5 months and get a booster. Does that answer the question? Sort of answer and sort of not answer the question. Okay. So, and Richard is just clarifying the 4th shot is only for people who are immunocompromised. I think there's another group of people whose circumstances have changed along the way, and there's not really clear guidance about that. So if you, you got your first 2 doses when you were not immunocompromised and now have like started cancer treatment, I think, again, the good news is you probably had a pretty good take of the original vaccine if you got it when you weren't immune compromised, like your antibodies have revved up. But I think that is a concern for patients, like, well, I'm going through cancer treatment now, what do I do? Let's see.
So I think the only other question, okay, we have the slides will be available today. Chris and his team put it up on the takecarenewmexico.org website. So as soon as this is over, we send him the slide deck, and then he'll also get the video up for those who missed the information today. And then, Richard, what do you mean by would you be giving some to EMs to distribute? So sorry, do you mean the slides?
No, ma'am, I meant like the N95 masks.
Oh, yes.
Okay.
Yeah,
Yeah,
we
'cause,
would love to do that.
That'd
Yeah.
be great. We'd love to, we could do that because we're getting requests already for some.
Okay, and that will be, I'm not sure when that allocation is coming to us. That's the only thing we're waiting on it, but we can, as soon as we have that, we will definitely reach out to you guys.
There's a question for children 5 to 10 years. What advice to parents regarding very low weight children on whether the shots were tested by age or by weight? They were definitely tested by age, and concerned that vaccine will be too strong for very low weight. And, that is a tough one. I think, that reassurance that it's already a third the dose of the adult vaccine hopefully would be reassuring in that situation. Also, you never want to kind of invoke mistakes, but there's definitely kids 5 to 10 who have gotten by accident the adult dose and no adverse effects. I mean, that particular child may have had a lot of side effects, but nothing that's rising to some critical level. And then there's also that just interesting, for the kids whose birthdays are crossing, who are turning 12 between the first and second dose, can really choose whether they want peds or adult vaccine. So I think that kind of sense that, it is very safe. They did lower the dose for the younger age group. But anyway, so I hope that helps. And then for the 6-month to 4-year-olds, and again, this is just kind of what we'd heard along the way, nothing new, but that will be even a lower dose. And in the original trials didn't produce enough of an immune response, so they added in a third dose. And again, for kids that age who are already getting a lot of vaccines, I think it's going to be a challenge for us with another 3-dose series. But so anyway, just something to think about. And I don't have, what we've heard is sort of first half of 2022 that we will have that vaccine available and approved for use. When we tried to, at least on a call I was on, someone was trying to press the CDC and they said, is it going to be 2 weeks or 4 months? And they kind of said somewhere in between there. So anyway, we'll let you know as soon as we hear anything a little bit more definitive about that. And also, like I said, very interested to hear how your practices plan to do it. Again, sort of have the thought it's hard to give a 6-month-old a vaccine in a drive-through situation. So sort of feeling like we probably are back to more office-based. And then, we've talked about before, but a lot of pharmacists who've done tons of vaccine, but usually don't give them to kids that young. So that might push this group more to, outpatient providers or primary care providers.
And then there's a few other questions here too. So the 4th shot is for immune compromise only, right? Yes, I think.
Yes, I'm just laughing at Tanya saying the car seat works wonderfully for the
Yeah.
6-month-old getting a vaccine or tested. I agree.
That's awesome. And then Dr. Darwin added a great link here to IHS utilizes the CDC's interim recommendations for COVID administration vaccine errors and deviations from best practice documents. So thank you for adding that. And then someone said, please send me the HANs. And so I just sent the link here to the actual HAN. You can just get it directly from our website now, but also there's a link that's a ReadyOp. It says ReadyOp link. That's the link to if you want to sign up to get it directly to your email. So I think that, yeah, so other than immune compromise, everyone else will receive 3 doses total, correct? Yes.
At least for now.
For
and
now.
Again, for now, I think we have talked about Israel did start a 4th dose for people 60 and over. And again, just a very preliminary, just in the news, it sounds like maybe it hasn't been a fabulous boost. The boosters are definitely showing and there were a bunch of studies, and the CDC highlighted them, that the boosters really are helping immunity against Omicron. It's not clear that a fourth dose like added that much. So, you know, it doesn't seem like we'll be in a rush to do that, but it is intriguing that Pfizer's starting with variant specific vaccines. So that'll be interesting.
Great. All right. I don't see any more questions. So I hope we answered.
Please feel free to unmute and ask, though, if we either got your question wrong or haven't answered it.
Okay, so this is a question. It says, is New Mexico planning to sequence for BA2 since it does not have the S dropout? I'm not sure. That is really probably a question for Mike Edwards. I can push that up to our director of the state lab to see if we're planning to sequence that. Do you know anything, Miranda? I don't know anything about this.
I mean, only to say, and I'm not exactly sure that we are, the state lab does sequence, you know, a certain proportion of positives. And they have been sequencing all along. Now it's mostly Omicron, but, you know, they kind of have the tally, and we can show that slide next week. And then they do send some to CDC for sequencing. And I believe UNM is doing some. So there definitely is sequencing that will continue to happen. It just happens that the Omicron was, because it had that S gene dropout, which not every lab was able to see, but the state lab did use, it's like the TACPath platform. And so, and that is the platform that the S gene dropout showed up on.
And just to be clear, everybody, you probably all know this, but the BA2 is a new variant. That's just defining our terms here, everyone.
Yes, there's a couple hovering out there, which just, you know.
And they do sequence, like they look for everything when they sequence. So you know, if it's BA2 or whatever, they'll like track all of them, and then they look at what's most dominant. So they will, but like Miranda says, it takes like 2 weeks for them to sequence. So it's never like at the moment it happens. So yeah, but we can ask for next time.
Yeah.
Great.
I have a question to clarify.
Yes, hello.
Hi. Is the question of, I understand the whole explanation. If somebody is immunocompromised, you get an extra dose after your second dose, like 28 days after your second dose, and that will be part of the primary. Then you get your booster 5 months after, if you are doing the mRNA, like if you are doing the Pfizer or Moderna. I got that. But this particular patient is a cancer patient. They missed that booster. They missed that extra dose of the primary. They went ahead and got their booster after 5 months. And this particular patient had COVID last October. And then they came to the clinic right now. As a matter of fact, somebody is asking on behalf of the patient. So he came to the clinic now and was asking me, can that person get another dose? And I asked, what did he get? And he told me this. I said, actually, you've missed the sequence. I don't know the right answer. When I come to meeting today, I will find out and give you a feedback so that I will be sure. I said that because there's a procedure and protocol we have to follow. I know we give 4 shots, but there is a procedure how you give it for it to count. So yeah. So from the explanation I got, it's still a little bit hazy for me. Do I go ahead and give the first shot, or just say wait until the CDC advises us more, or until there are more information out there for us to work on? Because he missed the extra dose for the immunocompromised.
Right. And that's, I mean, I would say this is the very question that we are pushing up to CDC. And the first time we did it, first time I pushed the question up, that's when they responded like, oh, just give the other half dose as soon as possible. But what I didn't clearly communicate is these are people that are already 5 or more months out. So
Yes.
I guess I don't want to, I feel like at least for me, I would like to try to clarify just a little bit better what the scenario is. So again, if you realized in 2 weeks, oh shoot, that person should have gotten a whole dose, absolutely give the other half dose, and then the clock starts ticking towards 5 months for the booster. But I kind of feel like the scenario that keeps coming up, what you're saying, and what we've been messaged is slightly different. It's someone who's totally 5 months out from.
Yes.
Yeah.
And the only thing that happened is they missed that extra dose.
Yeah.
Every other thing, if it is a normal person, the person has gotten the whole thing. So there's nothing like giving half to complete this. It doesn't come in because everything has been packaged as it should.
Right. And obviously this isn't really a problem with Pfizer. Like if this scenario is happening in Pfizer, just consider that third dose, the extra dose. Like there's no time limit. It's supposed to be at 28 days, but it, because all the doses are the same, you can do 2 doses of Pfizer. Even if the person waited 5 months to get that third primary dose, that's the third primary dose. And then 5 months later, they can do their booster. The hard thing is Moderna, because it's a different dose. So
yes.
I hate to not give you an answer, but I just don't feel like I have good clarity. And if, we were hoping to get it nailed down by this meeting, but didn't. We have a couple partners on our immunization team who are awesome about like trying to get the answers to these questions. So I'm happy to email you as soon as I know, and then we will also report back on this call. Because my guess is that the guidance just doesn't exactly exist. So hopefully we will get an answer.
Thank you so much.
Yeah.
I appreciate that.
Yep.
This is Tanya. I have a question for Chris.
Here I am, Tanya.
So 2 things. One, is there any way, so I've had a lot of organ transplant children 5 to 11. I've had 5 of them now. I have told those parents just to call me in 21 days so we can schedule them for 28 days. It doesn't look like there's an easy way for the system to push them into a booster queue. Am I correct?
Well, are they?
Because it would be their third dose since they're immunocompromised organ transplants.
That is correct. There is
There's not a button for me to click. So I just want to make sure I wasn't missing anything. And
what we can do is, let me think through that. What we may be able to do is like a batch upload for you, so that if you just get their confirmation codes, you can, well, let me think about that. But yes, we can look at a quick scheduling feature there.
And I've been very clear on those parents, I'll get you in on your 28 day. Next question is Pfizer, and I reported it Thursday, when I schedule a ped clinic and I click peds Pfizer, if I forget to look, it doesn't mark kids, it marks 12 plus. I've been really good about that. But I did have a pediatric 9-year-old in an adult clinic. I don't know if the parents changed the birthdays after they scheduled them. And, I haven't had any, I'm not sure the system's letting them in, even though it says 12 plus. I think it's still got them blocked out on the peds.
Okay,
I adults register in there, but on big places that don't have as much time as me, I worry that maybe they could.
Yeah, there's definitely some challenges that have been expressed over the last couple of weeks in terms of some adults getting into kids, patients, kids going into adults. We've tried to lock it down as best as we can. We see a whole host of reasons for that. One of the things that you're talking about is in the vaccine permissions. It defaults the permission setting to 12 plus. And what we can do is put some logic in there that if you select the vaccine Pfizer for kids, that it changes that default to the kids. So I'll talk to the team today about it and hopefully have a good update for you guys on Thursday.
Thanks. Kids are really slowing down. So is Moderna. Now it's kids 12 plus boosters that are picking way up.
I think that's what we're seeing, and Dr. Durham, Dr. Patajon, feel free to jump in here, but I think that's what we're seeing somewhat statewide at this point. I think last week we did right around 46-ish thousand vaccines. That's almost half of what we were doing almost a month ago. And I just want to remind everybody, it took us almost a year to get, what are we at? Almost 77. Hold on, let me get the actual numbers. 77.1% fully vaccinated. Boosted, we're at 40.8. And we've been at this for almost 3 months now. So the rate at which people are getting vaccinated for their boosters has been good, but it is absolutely slowing down. We're doing everything in our power to up the appetite, but we're seeing just lower numbers almost in every category. And with that mic drop.
Still better than last summer, though.
Oh, okay.
Yeah, I don't know what other people have tried, but it seems like there's definitely a slowdown. And I don't know, some of the thoughts have been like, should we go to more schools, or are there hours that parents would rather go to? Just love to hear from people too, what they've tried and had success with, or what you think we should try to do more of, right? Should we go to more schools? Should we, have evening hours? I think we've tried a lot of different things and still not getting a lot of uptake. And our mobile teams, like Miranda and her team, have been working on that. And, there's numbers, but not super high numbers, right? Oh, parents like Fridays and Saturdays. Okay. And then at how many weeks pregnancy do we start giving COVID shot to women? I think that's at any time. Yeah, you can get, and that's also another really low rate of vaccines has also been in pregnant women. And then obviously we see there's a lot of pregnant women who are disproportionately affected by COVID. So just let us know if we should be trying to do more campaigns, or I don't know. I think everyone says they trust their doctors and providers the most. So I think, people are listening to all of you for getting vaccines.
So can I inject a quick question? So, because I know before now, when you do your TDAP, you started at 27 weeks, because this is really what is happening in my clinic. So I got a 23rd week pregnant woman that came in. To me, with my little knowledge, I said it's not up to 27 weeks. Can I talk to your doctor? So they gave me the phone number of the doctor. I called them and left a message, but the doctor was graciously enough to reply me. And I spoke to her and she told me, they said it's as soon as possible. Then I asked her, can I see the literature? She sent me a lot of literatures, which I read, but there is no specific week you will start giving it. So does it mean, even if the letter, I have somebody that is 6 weeks and somebody that is 9 weeks. So does it mean even if they are pregnant, even if it is one day, they just found out they are pregnant, never mind, just go ahead and give the shot? Is that correct? Because I'm a little bit confused, because I know in pregnancy with other medication, at least in pregnancy, when you are giving TDAP, you wait until the pregnancy is like 27 weeks before you start giving. And I don't want to toy with anybody's pregnancy or anything like that. So I told them, let's talk to your doctor. And they said, yeah, you can give it at any time. But the literature I read didn't specify the time at all. It just said, give to the pregnant women. It's not telling me what I should do. So that is what scared me. And it looks like you just give it.
Yeah, I have not seen anything that gives a time frame. Like you're right, TDAP is a third trimester vaccine. I think some of that is trying to increase antibodies for the kid against pertussis for the baby. And then obviously there are some vaccines, the live virus ones, that you just don't give in pregnancy. So it is true that, it's certainly not universal that any vaccine can be given at any time in pregnancy, but have not, you know, there's no time recommendation for the COVID vaccines.
I'm scared. I don't want to do something
I
crazy.
would say if it's a concern, I mean, I think certainly like the what you have kind of pointed out is that like the first trimester where you're having the most most fetal development, like a lot of, you know, that may be a time to avoid, but it also could be a really high risk time if you got COVID. So a lot of these things, you know, I do think it is sometimes like a risk benefit analysis, talking through with your patient. If you've got a patient who kind of never leaves the house and is pregnant and wants to wait until second trimester, you know, that seems reasonable. But if you've got someone who's out and about all the time, then the risk of having, of getting COVID is probably, you know, is higher potentially than getting the vaccine.
Okay, thank you.
So
I just
guess
want to
that's
make
kind of
sure.
how I would, you know, I think with pregnancy, the other point you are making is just like, it's always good to have a discussion, you know, with your patients about that.
Okay.
About risks and benefits of anything.
Okay, thank you so much.
Yeah. Oh, and someone is, I meant to do a little plug for the UNM COVID Echo. Dr. Sosa, in infectious disease, every Monday at noon, and unfortunately I've missed it the last couple of weeks, but he like races through a bunch of the most recent studies. We also have Marla Sievers from Department of Health will also do updates. And oh, am I going to forget her name? Dr. She works up in Espanola and she does outpatient some studies, outpatient studies. Dr. Leslie Hayes, thank you so much. And anyway, that is a great resource as well, a great way to spend a lunch. And it looks like Dr. Sosa maybe addressed is that addressing the pregnancy issue? And yeah, okay. So we can do a little more looking into it and maybe dig up whatever article he presented and bring a little more information next week. And one more question, an immunocompromised patient should have received 3 doses of the same brand, and now the 4th dose can be any of the 3 brands, and that is correct. That is correct. All right, well, thank you for all the amazing questions. We will try and do our homework and come back. And thanks for your time and attention and joining. And we will see you next week at this time.
Thank you.
Hi, team.
Thanks.
Bye. Thanks.
Thanks.